proximity to a provider where a patient may have to travel, 300, 400 miles to see somebody, so they're having to take a day off of work. They're having to, stay the night in a motel in some cases. If it's the middle of winter, they're not able to go. So proximity is an issue. In terms of actual providers, there was a grant about 3 years ago with Dr. Richards based out of Sheridan, Wyoming. He was focusing on Title 25 and a project that he was working on. And in that grant, there were 14 psychiatrists in the state that he partnered with at that time. Of those 14, there's one left. So the actual number of providers from that standpoint for accessibility, they're just not available. It's not that there aren't great providers out there. There just aren't enough. And then I think the other thing that is important is the stigma that is attached to mental health care, especially out here in the West, where people are raised with the mentality of, you pull yourself up by your bootstraps, and, it's a can-do attitude that you get it done yourself and you don't need help. So there's that mentality, along with, I'm a person that may need some help, and I know that I can go down the street to a mental health care facility, but I'm not going to park my car in front of that because I know that the rest of the community is going to know about it by the end of the day. Primary care providers in these small communities of 2,000 to 3,000 people are just completely overwhelmed with the problem, knowing that they can't get a patient in to be seen, and it's not accessible. So they're having to manage this issue on their own. Is something they're not comfortable with. So HealthLinkNow coming in and giving them this model of care that's patient-centered, integrated into their practices, is something they're very, very excited about. What that meant and what that should look like in rural United States is finding an innovative solution so that we can place a technology that's integrated into small practices in these smaller communities that allows patients to have access to specialist care, in this case psychiatric care, with a provider that can be based anywhere in the country. And so that was really the basis in working with the Center for Medicare and Medicaid to approving this project, something that really hasn't been done before in terms of how we're going about using this patient-centered model, but also using this technology that is from an IT standpoint is based out of these local clinics, so the patients have access when and where they need it. I think there are a number of things that need to change in order for healthcare reform to really take hold, and what telehealth in particular looks like. So first off is you just had talked about licensing, practicing across state lines. So why would we require a physician who is a physician in Colorado, who is a physician in Wyoming, to have a license to practice in another state when they can provide a model of care that is effective over video? Why should we have to go through that process? That's one, I think, legislative issue that we need to look at. The second is credentialing. If we have a physician, and this is the case right now, where we are in 20 different critical access hospitals in Montana, and we have 1 or 2 physicians that are managing the caseload for those patients, why should we have to go through the process of credentialing with different forms and taking 2 and 3 months to provide care to these patients that really need it right now? The really nice thing about our technology and what we've been able to do with the video technology we've set up is it does not require typical broadband speeds. You need two up and 2 down, to get a very quality video feed between our provider and the patient. So most of these rural communities, even the very small ones, have the ability to set up this service and the technology that we have to make this work. The other really nice thing about our technology is the expense to the clinics to get it set up. So, if they already have an existing device, laptop, computer, or a desktop, really all you need to buy is a high-definition camera and a noise-canceling microphone that's plug and play, less than $150, and you're off and running, as opposed to these legacy video systems that require a network and a $30,000 to $50,000 layout. I mean, this is where technology is going. Web-based technology and what we provide these clinics is why they are doing this and why they didn't do it in the past with the very expensive devices, especially in some of the very small communities where they haven't seen something like this before. A good example is I set up a clinic on the High Line of Montana, which is like 10 miles from the border of Montana or of Canada. And the woman that I was setting this up with remotely had never been on a computer. She doesn't have a cell phone. She doesn't have an email address. So this whole process for her and getting it set up was brand new. And the neat thing about it is once she learned it, it's the only thing she knew on a computer. So her surfing around and setting up a patient, getting them onto the video portal and speaking with our provider was, she was great at it once she got it going. So I think there are roadblocks in those terms just because it's a new technology. But, after they've done it a couple times, whether it's the clinic or the patient, they're very comfortable with it, and, it does work. Once they're, sitting down in front of it and, seeing somebody face to face, it's just like being in front of a person. And I think after a few minutes, they're very comfortable with it, even if they hadn't done something like this before in front of another, video technology. The key to all of this is showing what happens when you introduce mental health care to patients that have never had it before. And so that means a couple of things. For a small community, that means reduced visits to the ER, which are overwhelming to these small critical access hospitals. It means reducing the number of cases where you have these chronic issues with patients that are related to mental health care issues. It means staff time and for these critical access hospitals so they can focus on things that maybe they weren't able to focus on before that are more important. It reduces the number of trips that local law enforcement, where there may only be one or two in a community, having to transport an involuntary patient to a mental health care institution that's across the state, and needing both of them to travel at the same time. It's reducing costs in a lot of ways outside of healthcare, but it's also reducing patient costs in terms of ER visits and chronic issues. Over the next 5 to 10 years, I don't think there's a more exciting place to be for rural America in terms of healthcare than this. And I think the bottom line is, once the outcomes are shown from this project and other projects that are ongoing with CMS, is this technology will provide access that's needed. A. B. It's going to give the outcomes to show that people are healthier in rural parts of the country and in urban parts of the country where we're doing this. And the last thing is it will lower cost. And in terms of healthcare reform, that's what this innovation is all about: is better health, better access at a lower cost. And so that's what we do.